Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Understanding the Mutual Relationship Between Income and Mental Health and Strategies to Improve Outcomes, presented on behalf of the Association of State and Territorial Health Officials, also known as ASTO. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we'll now begin today's presentation.
Welcome, everyone. I'm Caitlin Langhorne-Griffith, ASTO's Director for Injury, Suicide, and Violence Prevention, also joined by my colleague, Allie Maffey, Vice President for Social and Behavioral Health. For those of you that might not be as familiar, the Association of State and Territorial Health Officials, otherwise known as ASTO, is a nonprofit organization committed to supporting the work of our state, territorial, and freely associated state health officials, with a special emphasis on furthering the development and excellence of public health policy nationwide. Our primary functions include developing strong and effective public health leaders, improving public health through capacity building, technical assistance, and thought leadership, and finally, advocating for resources and policies that improve the public's health and well-being. For today's webinar, we'll hear from colleagues from the Center for Law and Social Policy, and after their presentation, we'll have time for questions, breakouts, and reflection, and then we'll wrap up. As a result of today's webinar, we hope you learn more about the relationship between income and mental health, strategies and policies for reducing poverty and improving mental health, and finally get to learn from peers about serious mental illness or children with serious emotional disturbance. And with that, I'm going to turn it over to Nia and Isha to introduce themselves and begin their presentation. Thank you so much.
Thank you, Caitlin. Hi, everybody. Good morning, afternoon, depending where you all are calling in from. My name is Isha Singha. I am the Associate Director of Mental Health and Wellbeing, and I am here with my colleague, Dr. Nia Westbay, who's the Director of Youth Policy at CLASP. And we're going to talk to you all about this relationship between poverty and mental health, some of the strategies that we've used to improve mental health outcomes, and how we go about our work. So we wanted to just give you a little bit of a background about CLASP. We are an anti-poverty organization. We are nationally focused. We focus on removing barriers from people who experience economic hardships and want to work towards economic security and opportunity. Although we are national, we work on the federal, state, and local levels. We focus on policy and advocacy, and we really try to serve the people that are experiencing poverty by including people with lived experience and centering racial equity. So our mental health work in its current iteration has been going on for about 7.5 years since Nia started, and really is based on some foundational work that Nia did in focus groups with young people, learning from young people across the country, focused on young people sitting on the margins about what they needed and how they framed mental health. We started to expand that work to focus on maternal mental health as well, and now work on immigrant mental health, the intersections between mental health and paid leave, for example. And and also focus a lot on Medicaid. These pictures on the left are only some of the reports that we've released, which have created the foundation for our work, which all include voices of lived experience, all center racial equity. But we've done work, like I said, what Nia had done in terms of looking at focus groups, but we've also focused on police-free mental health, which is the Youth Mobile Response Services report. We focused on how the opioid epidemic has impacted Black and Brown populations. We've focused on what youth and young adult systems need to focus on in order to better serve young people. And on the right, I'm going to focus on our core principles to reframe mental and behavioral health policy. So these reports help to inform those core principles, as well as the insights from a mental health advisory board, which we had pulled together, who focused on state, local, and federal strategies, but also had lived experience and centered racial equity. So those core principles, we have 6 core principles, and you can see the link on the bottom left-hand corner. So the first principle is we need to redefine mental health. A lot of what we've heard from young people and from people and adults as well, in terms of those who have lived experience of poverty and mental health, is that we have to redefine the way that we think about mental health. It needs to be focused on asset-based instead of deficit-based. It needs to be community-informed. The second principle is focused on expanding access to care. So yes, absolutely, that is in terms of coverage, and that we believe in universal healthcare coverage, but we also believe in parity, so that physical health services are covered at the same level as mental health services. But we also believe in a holistic view of mental health, that the mind and body should not be considered separate. We believe that mental health is at the core of a person's livelihood, and that interventions and supports need to happen beyond the traditional health visit, that it could be in your community center, it could be at your place of worship, it could be after school. We need to be very creative in how we think about mental health support. The third principle is that mental and behavioral health services have to be culturally responsive. So this is new, but we also try to emphasize the long history of criminalization in the mental health system and how it still rears its head today. One of our colleagues just wrote a report about that, which we can share. And then we also have to acknowledge the reinforced stigma in communities due to cultural norms, due to racism, due to discrimination, which has led to discomfort and distrust of the mental health system. The fourth principle is to address social needs. So yes, very much so focused on the social determinants of health, but we also try to look at that broader definition of SDOH to think about the root causes, and we'll talk about this too, the systems of power, like racism and discrimination, like housing and food insecurity, job quality, the built environment, and how people with low incomes, especially people of color and people with other marginalized identities, will continue to experience negative mental health outcomes, and propagate intergenerational trauma if these systems of power are not addressed. The fifth principle is to strengthen quality infrastructure. So we absolutely believe in better data collection, focusing on community level data, but that data collection is also comprehensive, that it is also culturally responsive, that is really meeting the needs of communities and also meeting and understanding the levels of distrust in these communities. And also that it comes with provider sensitivity training. And then the sixth principle is to build a robust and diverse workforce. And when we talk about diversity, we're not only talking about race and ethnicity, we're talking about diversity of the ways people provide mental health services. We're big proponents of supporting peer support specialists, for example, doulas, the breadth of experiences that people can provide to support mental health care. And with that in policy, we need to really think about who is considered qualified to meet community needs. So with that, I'm gonna pass it over to Nia.
Thanks, Isha. So as Isha already mentioned, I am the director of the youth policy team at CLASP and have really had the opportunity to help to lead our youth and young adult focused mental health work. So I just wanted to share a few pieces with you all to set the context for the conversation. Some of them Isha has already alluded to, including this very first piece. So we did our first round of focus groups with some young people, African-American young people in the Southeast United States back in 2016 and 2017. And one of the very first things that we noticed coming out of those conversations was that the way that young people were talking about mental health was very different than the traditional sort of clinical model that a lot of folks think about when they think about mental health. They were not just talking about what they didn't want or what they didn't want to experience, but who they wanted to be, skills they wanted to develop, ways of being in the world, and that being really core to what they thought of as mental health. So that's sort of a first point that informed the core principles that Isha already outlined. Young people are thinking about this, have been thinking about this differently for quite some time. And that is, it's important to understand what that different framing is and its implications for our policy and practice choices. The second piece is to set some context on poverty. So folks are often surprised to learn that young adults are, especially in recent years with some of the policy choices that were made, one of the groups that experiences the highest poverty rate of any demographic group in the United States. So when I talk about some of the choices that we make in terms of our policies, we actually saw a huge drop in child poverty. Children are also another group that is historically very high in poverty, but there was a huge drop in child poverty during the pandemic when the child tax credit was in effect. I think we'll talk more about that throughout this conversation. No comparable impact or limited impact for youth and young adults. So that tells us that poverty is a policy choice, and that there are things that we can do differently that will significantly reduce poverty. And this just also reflects that the limited impact that young people experienced during the pandemic in terms of sort of leveling out poverty levels, as of the most recent data available, that level had jumped back up. And that was the highest level of young adult poverty that we had seen since 2017. Now, one of the big questions that I think we're going to try and untangle during the course of this conversation is around the relationship between poverty, serious mental illness, and other types of mental health challenges. So this is some data from the National Survey of Drug Use and Health, a data set that I love because it makes it very easy to look at outcomes by poverty level. So the big takeaway that I want to flag for you all here is that you actually don't see more serious mental illness when you're looking at young adults when you go below the poverty line. In fact, it looks like serious mental illness is showing up at a slightly lower level when you go below the poverty line than when you're above the poverty line, right? Similarly, we find that for serious thoughts of suicide, the risk level below the poverty level is not that different from those above the poverty level. The real risk factor for these things is being young. So when you look at these numbers compared to older adults, then we find some differences where these rates are higher for young people, but they're not particularly different by income level. The only place where we see some differences by income, where folks living in poverty or with low income are at higher levels than other young people, is when we look at serious psychological distress in the past month. So when you think about just sort of broader challenges of daily living that young people are talking about, then we seem to start to see some income-related impacts, but not necessarily when we think about diagnosable conditions or something like suicide. And we'll come back to what we think that means during the course of this conversation. The last thing I wanted to share is a couple of quotes for some of these focus groups that we've alluded to. What's been really interesting, as I mentioned, we did some focus groups back in 2016 and 2017. We actually got to do a different set in partnership with ASK, though, in 2023. And the similarity in the types of quotes that young people were sharing in 2023 versus 6 or 7 or 8 years ago is like astonishing. But this first quote from 2017, a young person shared, "I feel like it all come down to money, because when you're struggling and stuff, you're going to do what you got to do. Money don't make happiness, but when you can't do nothing without money, you're going to snap, bruh. The pressure is going to be too much, and not everybody can handle that pressure." So that was one young person's take back a few years ago. And then more recently, we had a young person share, "We're talking about trying to find even like basic income. Like we're talking about putting money in the pockets of low-income Americans so you don't have to have these other stressors that we're talking about, all of these other interrelated factors." The moral of the story from what we've been hearing from young people consistently since we started this work is that an anti-poverty intervention is also a mental health intervention. We've got to end poverty to really make a significant difference in the mental health challenges that young people are experiencing. So with that, I'll turn it over to the facilitator to take us into the discussion.
Thank you so much, Nia and Isha, for laying an exceptional foundation for the work that's happening at CLASP. We'll now move into a fireside chat format with some questions for Nia and Isha to answer, and a reminder to participants that you can share any questions that you have for the CLASP team in the Zoom chat. So just to start us off, could you talk a little bit more about how your work assists people with serious mental illness and serious emotional disturbance? You did a great job with setting the stage with some of the data, but we'd love to hear more.
Sure, I'll start this off and then maybe pass to Isha for a little bit more. So CLASP's approach when we're entering a body of work is to really do an assessment of sort of the landscape and who's doing what work and how we can be a unique value add to whatever the topic is that we're focusing on, right? And so when we started to re-enter, I say re-enter because back in the 70s, CLASP actually had a body of work focused on mental health that is now the Bazelon Center for Mental Health Law. But when we were re-entering the work, we really wanted to both have these conversations with young people that we're talking about and just sort of assess who are other organizations in the space, what kind of work are they doing. And I think one of the conclusions that we came to is that CLASP did not provide the most unique value add by focusing sort of explicitly and solely on serious mental illness or serious emotional disturbance, right? And it's partly because of the pieces that I talked about. The link between those sort of diagnosable conditions and poverty is less clear. But we are also the belief that a lot of the things that support folks' mental health along the continuum of mental health challenges are beneficial to everybody, including folks with serious mental illness and serious emotional disturbance. So I have certainly in my role advised, been an advisor to a group that is focused on serious mental illness in the Black community. Isha also has some experiences in that space, but we really have prioritized our focus from a policy perspective on a broader range of outcomes, because it is also our belief that from a policy perspective, that bifurcation of sort of carving off folks experiencing serious mental illness or serious emotional disturbance from the rest of us is not super helpful and productive. I'm going to pass to Isha to add.
Thanks, Nia. I'm just going to echo, Nia, what you were saying, and also add that I come into this space as a caregiver of someone with serious mental illness. And as we are immigrants and have experienced racism and discrimination in the system throughout this whole course of my family member's illness, I just want to echo everything Nia was saying about if we don't address the main drivers of what is causing barriers to care, we're not going to be able to serve people with SMIs. And I see that every day.
Thank you both for that really thoughtful and vulnerable answer. Thinking about the young people that you serve, could you share a little bit more about how your team involves young people and stresses the importance of youth voice? And I think you got at this towards the end, Nia, but would like to hear more.
Absolutely. So I didn't think about putting this in the slides, but there's a tool that we use a lot that is called Hart's Ladder of Authentic Youth Engagement, which it's an 8-rung ladder. There are 3 rungs at the bottom that are terrible. We don't want anybody doing that. But there's sort of a set of ways that you can engage with young people that are the top 5 rungs that just sort of imagine different levels of youth adult partnership, different levels of decision-making authority between young people and adults. And we have been striving over time to really push towards the top rungs of that ladder and as much as possible, think about how we can be in truly sort of co-creation and partnership, direct partnership with young people. But we didn't start there, and we're not there in every project, and that's not what's required at all times. Things like focus groups are somewhere around the rung 5 on the ladder, where we're maybe leading the project, but we're getting young people's input. There are sort of collaborations where maybe it's initially an adult idea, but then you bring in young people to lead. So we are sort of in all the places along that continuum with different projects, everything from focus groups to an initiative that we have called A New Deal for Youth, where the mental health component of the agenda was developed by and for young people, and young people are now working to try and make that part of the agenda happen. So lots of cool things all along that spectrum. As you said, I think I've already alluded to some of the things that we have learned and done differently as a result of those collaborations. And I'm so thankful for. One is, as I said at the top, this focus on wellness and the importance of what we are trying to be and come and grow into as we develop, as opposed to just sort of things that we're trying to avoid, as well as the importance of sort of non-clinical approaches and models, I think has been a big theme coming out of conversations with young people. Another one Isha alluded to is this focus on peer support. I think we heard from young people first, the importance of engaging with folks with shared experiences from the same community that look like you, all these types of things and roles that peer support specialists fill that has informed our advocacy in that space subsequently. Another thing that I really appreciate about young people in this space is I feel like they are so much further ahead of us more seasoned adults, as I sometimes say, in terms of issues of stigma around talking to mental health. Like, it is so normalized for young people now to talk about mental health. My own daughter, we were in the car, we were listening to the Jasmine Sullivan song where the lyric is, "I'll bust the windows out your car." And my daughter was like, "Sounds like she needs therapy." Like, it's just been so normalized for young people that I think we as older folks have a lot to learn about how we normalize these conversations and make this something that everybody can be engaged in. And I think last but not least, the importance of focusing on root causes and issues like poverty as we think about mental health. I think young people have really bring that to the fore in a way that has been really powerful and emphasizes that we're only like messing with the surface if we don't get to these root issues. And we're going to continue to be cycling into these challenges if we don't get to those underlying issues.
Isha, anything that you would add to? No? Okay. At the end of your all's presentation, you mentioned the child tax credit and started to talk about the importance of policy, and wondering if you could elaborate further on the effective policy recommendations and potential policy levers to pull related to poverty and mental health.
So yeah, Caitlin, you hit it on the nail on the head. For sure, looking at key drivers like the child tax credit, as Nia had mentioned, universal basic income, affordable, no-cost housing, SNAP benefits, expanding SNAP benefits, looking at more providers who take Medicaid, going back to our principles and also what Nia was saying about peer support providers. All of these things relate to mental health and also align with what we talk about as mental health being the core of a person's livelihood. One thing that I do also want to stress in our work is that when we think about policy recommendations, we really, especially when we do policy technical assistance, we really try to focus on the individual system because every system is different. In the 6.5 years I've been at CLASP, every state and locality we've worked with have had different answers to how they want to address a certain problem issue. Even though the issue may be the same, the solutions are different. So I just wanted to say that it's not a cookie cutter approach.
Yeah, and I would add to that both gets at the question I see in the chat about poverty in rural communities. And just for the record, a number of the focus groups that we have done with young people have been in rural communities. So we really try and over the years have tried to span a broad range of contexts in terms of the young people that we're talking to, and then the different types of states that we're working with and communities that we're working with. But I think another important lever, particularly in general, but especially when you're talking about young people and when you're talking about rural communities, is telehealth and sort of app and text-based mental health supports. We hear so much in rural communities about the lack of availability of resources, or especially for sort of like LGBTQIA plus young people in rural communities that, or even school-based mental health in rural communities, you can't necessarily access a provider geographically close by, right? And the use of technology really opens up a lot more options in terms of young people being able to connect with the type of therapist they want, or the type of community they want, or the type of support that they want. So we did do quite a bit of work, especially during the pandemic, around some of the telehealth flexibilities under Medicare and Medicaid that happened in the pandemic. And it turns out we're actually responsive to things that young people were asking for well before the pandemic. Along the same lines, a huge piece of what we work on in this space is Medicaid levers, and thinking about what is reimbursed, what providers are available, what medical necessity means, because there's a lot of decision-making in the Medicaid space that is made at the state level. There's a lot of flexibility for states, for better and worse. That means folks can have a very different Medicaid experience in one state versus another. And we really try and uplift some of the things that states are doing well so that other states can be like, oh, maybe we can do this here too.
Thank you both. Thinking about innovative work and examples of effective or exemplary interventions, could you talk a little bit more about this in terms of what's happening related to the connection between poverty and mental health needs and outcomes?
Sure. One thing that I didn't fully describe in my last answer was around the systems of power, which is something that we really try to focus on as well. So I just wanted to address that too, which is focused on the beliefs, practices, and cultural norms on which individual lives and institutions are built. And we have a great video, which I'll put in the chat as well around that. So in terms of exemplary interventions, we focus both on the federal side and on the state side around prevention. So prevention of mental health, and not in the sense of in the stigmatizing way of thinking about prevention, but focusing on what kinds of supports do people need in their community to help allow them to thrive. So that looks like we've been advocating for a place in SAMHSA's mental health block grant focused on prevention. We've also been working on the state level around prevention and also early intervention, but our focus is more on prevention. One example that we have worked on over the past couple of years is in another part of our work in youth policy, we work with workforce agencies, mayor's offices that focus on the youth workforce. And over the years, we've heard time and time again from our partners about how young people come into agencies wanting mental health support. And so one of our partners is in Los Angeles, the city of Los Angeles, and they did something about it. They spoke with thousands of people, from young people to youth organizations to local educational agencies to philanthropy, and then came up with 6 priorities. 2 of those priorities were in career pathways and in mental health. And so then they are bringing peer support providers to help within workforce agencies to help serve those young people as they're getting workforce support, applying for jobs. They're also getting mental health support. So that's a very, very effective way to where poverty and mental health intersect. And we're really excited about that program.
Yeah, and there are a couple of other examples I would mention. So we talked about universal basic income in the policy piece. There is a group called Mayors for Guaranteed Income and also Counties for Guaranteed Income. There are sort of a combined organization of local localities, so cities and then counties, that are doing universal basic income pilots of different sorts in different communities around the country. And part of the reason that these folks are coming together is both to harness the power of these elected officials that are interested in this work, but also to do really rigorous evaluation. And for the sites where they have done evaluations, what they have consistently found is that universal basic income alleviates mental health challenges. And again, there's a range of type of pilots with young people, with adults, with sort of all sorts of folks. And across the board, the findings consistently from their evaluations are like, yes, it helps in terms of what they can buy for their kids and how they feel about taking care of their family and what their income looks like, but that also has mental health benefits. And then another example I wanted to mention is we did some technical assistance work with a county in Maryland where they had a HUD grant from the Youth Homelessness Demonstration Project. And there are sites for this grant all around the country, but sort of part of what's required is a cross-sector collaboration where folks are working together to identify the needs in the community and what it will take to eliminate youth homelessness in those communities, right? So that brought together folks from the education system, from the mental health system, from the health system, from the workforce system. Like all of these folks had to come together and build a comprehensive community plan in order to get the additional funding from HUD to execute the plan, right? And there's also a requirement in those grants that you have a youth action board that advises and oversees the implementation of the project. So that's a really powerful coming together of efforts to address youth homelessness, to integrate youth leadership, and to bring mental health folks to the table with all the other major systems that impact young people's lives.
We got a question in the chat and we have time for a couple more questions. How are you approaching state level advocacy, given that we are rapidly approaching an election between an administration that contracted service coverage for unhoused individuals and an administration that expands those services? Do either of you have any suggestions or comments?
My first thought is that when we still are, when we do state level technical assistance, we really try to encourage state agencies to partner with community groups to help not only to understand what the perspectives are from people who are experiencing the barriers, but also for the sake of sustainability. In the work that we have done in maternal mental health, for example, those community groups have helped, they could perhaps apply for grants that could help sustain a program beyond the limitations that a state level government may constrain upon an agency. So that's the first thing that comes to my mind. I don't know, Nia, what do you think?
Yeah, you're not alone in this complaint about sort of the unrealistic timeframes sometimes with federal grant programs, or the ways that things can swing wildly back and forth with different administrations that have different priorities. That's real, and I just want to acknowledge that. I think to Isha's point, a lot of the ways that we at CLASP think about that is what is the appropriate level for that particular change at that particular time, right? So maybe there's some kind of new barrier that has developed at the state level. Are there localities that we can work in to try and continue to move the work forward? Or now we have a lot of learnings from the local level or the state level. How can we push for these things now at the federal level? Or how can we create a feedback loop with federal folks about the ways in which these changes that they're making are creating barriers for us at the state level? I guess the other thing I would say that is also an observation after being in this work for quite a few years is that a lot of times folks will tell you a barrier is at a particular level. So like people from the state will be like, oh, it's the feds. And then the feds will be like, no, we never said that. The state decided that. So I always like a little bit cautious when people say that there's a policy or there's something in place at a different level that is preventing what folks want to do. Because a lot of time that isn't even necessarily a thing. The biggest example we have at this is in the peer support space, where there is a broadly held belief that there is a federal prohibition on certifying youth peer specialists under the age of 18. And we have searched high and low and have found no such guidance, barrier, evidence, et cetera. And I've actually really been pushing the federal government as a result to issue guidance to clarify that that's not something that's not allowed. So acknowledging the challenges, but I would just say laying some groundwork at other levels, both to try and keep the work going, to figure out where the problem actually is, and to figure out what is the right level for the right moment, given what's happening in the context, can be a strategy to think about.
That's helpful. Thank you. To close out this part of the discussion, could you share a little bit about who you're partnering with in this space and any successes or challenges you've experienced as a result of those partnerships?
Yeah, sure. We highly value partnerships, if that wasn't clear, what we've shared so far. We partner with a lot of young people. And we learn from them, as Nia had said, every day we're learning from them. We also partner with youth organizations. We partner with organizations that focus on mental health. We partner with organizations that focus on the related issues that we have mentioned throughout this time we've been talking together. We partner with state agencies, local agencies. We partner with federal policymakers from the White House to HHS, to SAMHSA. We are very open in terms of who we partner with and learn from. In terms of successes and challenges, I will say I'll start with challenges in terms of organizations that want to work with young people. Sometimes the way that organizations approach young people and the way that our philosophy is in approaching young people, there could be some dissonance. And so with some of the work we're doing, we're trying to make sure that we're on the same page and that we try to share the way that we are youth friendly in everything that we do, and ensure that in terms of thinking about what Nia was saying in terms of Heart's Ladder, that it's a constant process. It doesn't mean that there's like, you're wrong if you're doing things a certain way, but we'd like you to be more youth friendly. So that has been a challenge for us. Another challenge has been helping partners understand the importance of prevention, because it is a long-term solution, and as a society, we focus on short-term solutions. So with the bills that I was talking about earlier, there is the no diagnosis bill that Nia was leading our team on in trying to push forward. That was met with a lot of resistance because there's costs with the Medicaid agency, costs to the system. How can this provide long-term health outcomes? And we know as public health providers, as mental health advocates, that prevention can go a long way. Nia, I'm going to pass it over to you to talk about Utah.
Sure. I would say one success, again, at the intersection of all of these things is for the last 2 years, we have done a transition age youth policy summit in Utah, which has been really phenomenal in that we've been able to have folks from around the country share different policies that they're working on to support young people's mental health. We have been able to have a panel of young people that provides sort of real-time feedback and Q&A with the folks presenting on their policies. And ultimately, we're able to develop a policy brief that outlines some of the different cool things happening around the country as it relates to youth mental health, as well as think with young people about how those policies could be made better or how young people could be more engaged in the process, especially, again, young people from marginalized communities. So I know we're over time. There are more that we thought about sharing with you all, but we'll leave it with those for now.
With that, we're gonna move into a short breakout and give participants an opportunity to share learnings and insights gleaned from Nia and Isha's presentation and fireside chat discussion. So if you can take a moment in your breakouts to share a key insight and then any bright spots or challenges you're running into within your own work related to mental health and poverty. And then when you come back, pending time, we'll have a couple people share by unmuting, or you can share in the chat as well. So with that, I'm going to ask for Bailey to send everyone into breakouts for about 8 minutes, and then we'll come back and debrief.
Fantastic. Breakout rooms are opening now.
Thank you. In her room.
Yes, absolutely.
And Bailey, it also looks like Katarina Smith is in a room by herself in 2. As is Melissa Hagistek in 11.
Yeah, apologies, team. I'm working on moving these people around. They are either coming back to the main room or just dropping from the meeting. So
No
the
worries.
rooms are a little more condensed than first planned for.
No worries. It's a big jigsaw puzzle.
Surprising. Some people decide once it's breakout room time that they hop off.
Do you all not usually do breakout rooms on your calls? It's like like we had a lot of people here.
We did.
We've got about 5 more minutes in the rooms.
Sounds good. And Bailey, since we're a couple minutes over, I might just skip to the personal reflection after we do debrief on the breakouts. Just a heads up that I might skip over the curiosities slide since we did have time to answer some questions already during the fireside chat.
Okay.
We'll see how quiet the group is with debrief after the breakout.
Sounds good. And would you like me to send out a message, 1 minute warning?
I'm on mute. Sure, that sounds good.
Sounds
I
good.
guess you read my lips.
I did. But thank you. All right, team. The team is, or we'll go ahead and close the breakout rooms now. They'll get a 60-minute timer, second timer, and they'll return here to the main room.
Welcome back, everyone. We hope you enjoyed the opportunity to connect with some peers that are also working on mental health and poverty. We'd love to hear how your breakout group discussion went. So if you can take a moment to share any takeaways in the chat, or if anyone wants to come off of mute, we welcome that as well.
One thing that was nice is hearing some of the other communities that have transportation barriers in rural areas. Even though from New Jersey, where we live in New Jersey is really rural, my town is 1 square mile, but we have one of the largest geographic areas, and we also had the only workforce shortage in behavioral health care in the state. And so that's always been a barrier. So it's interesting to see how others are navigating, and also even with the influx of telehealth services being available, that still requires families to have an infrastructure of access to broadband internet, of having access to the actual tools, like computers and things like that, and then also being able to use those tools as well. And so trying to find creative solutions to bridge that gap. So I appreciated my breakout group. Shout out to team number 4.
Absolutely. Thank you so much for sharing, Marissa. We appreciate it. Anyone else? Takeaways they would add from their breakout group? With that, we're going to go ahead and move to reflection. So to close out the webinar, we'd love to hear about a next step that you're committing to take, whether that's a step that's within your agency, but does not require additional approval, funding, or assistance from anyone else. This is something that you personally can do. And this is under the umbrella of reducing poverty and improving mental health. And so go ahead and take a moment to think about it, and then share in the chat if you feel comfortable. So one small action that I commit to take is. Seen a couple of comments come in related to education and taking advantage of the resources out there, sharing data and information in work groups, encouraging people to talk about it openly, so important. Actively engaging youth in policies, programs, and practices. All really important next steps, and thank you for those that have shared. With that, we're going to go ahead and wrap up the webinar for today. Isha and Nia, thank you so much for sharing your knowledge and expertise with us today. The presentation was fantastic, and your answers to our discussion questions, we really appreciate it. And thank you to our participants for joining us and remaining actively engaged till the end. We hope that you'll follow up if you have any technical assistance requests, comments, or questions. And I will turn it back over to Bailey to close us out. Thank you again.
Thank you so much. This does conclude today's session. You may now disconnect.